Prashant, you can start your session.
Thank you. Good afternoon, doctors. Welcome to this webinar on the rational approach to viral respiratory tract infections. Today we have got Dr. Pramod Jog sir as our moderator. This program is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993, and we have 30 plus years of excellence, 36 state-of-art manufacturing facilities, 300 plus products in portfolio, and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, APIs, and FDFs in the world and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. Today's webinar, we have got Dr. Pramod Jog sir with us, as I said. Dr. Pramod Jog is MD, MN, AMS, FIAP and FICMCH. Sir is PG Diploma in Pediatric Infectious Disease. Best performer at ADVSC France 2011. Sir has done MA in Sanskrit with proficiency in French and Spanish. Director WUM 18. Professor of Pediatrics at D.Y. Patil Medical College, Pune. Sir has been National President, Indian Academy of Pediatrics, IIP 2016. Standing Committee Member, International Pediatric Association. Steering Committee Member, GAVI, CSOSC. Standing Committee Member, ASPID. Consultant Physician, Consultant Pediatrician, Medipoint, Jupiter, Ankura, New Sangavi and Dinanath Hospital. Senior Consultant to UNICEF. Member, Maharashtra State Pediatric COVID and Measles Task Force. This brief introduction, I hand over the session to Dr. Pramod Jog. Sir, over to you, sir.
Thank you. I hope I am audible. I will
Yes,
just
sir.
share my screen
Yes, sir.
so that wait. I hope now the screen is visible. Huh? Okay, right.
Not yet, sir. Yes, now it's visible.
It is visible. Okay, very good. Thank you. So basically, today's talk is related to rational approach to viral respiratory infections, and it is very important to understand some important words in this particular title. It is a rational approach. So rational means one which is appealing to the conscious, and one should be aware that whatever I am doing is right, whether it is wrong, and he should be aware of it. So many times, there is a difference between what we say right and wrong and rational. Sometimes, for example, if a person is bedridden and is very very serious, and at that time it may be very difficult for the treating doctor to take a rational approach. Though the right approach could be that he has to be given all the necessary treatment and whatever is the end of life situation and all. So rational means in a given situation you must behave what is right and what is proper and what is appealing to your intelligence. So in case of respiratory infections, we are going to discuss about the rational approach, and that too in children who have viral respiratory infections. And that is why it is extremely important to understand that the viral respiratory infections in pediatric practice today are the ones which form the majority chunk of pediatric practice. I must say, is the bread and butter of practicing pediatrician. And whenever a pediatrician sits in the OPD since morning till evening, all the patients coming to his OPD, almost two-thirds of these patients are of respiratory infections. And it is very important that in first place, the pediatrician understands whether it is viral or bacterial. Whenever a child comes with fever, cold, and cough, and if more than one system is involved in the child, for example, the same child has cold and cough, the same child has vomiting and diarrhea, the same child has rash, the same child has some rhinoconjunctivitis. So all that, means that the infection is generalized. It is not localized. It is not that the child only has a follicular tonsillitis with cervical tender lymph node. If that is the case, when the infection is localized and the child has fever with follicular tonsillitis and tender cervical node, it becomes a bacterial infection. So a child with bacterial infection will not have associated chest signs. He will not have associated bacillary dysentery or blood in the mucus. So at a time, only one single system will be involved. Now, if a child has blood and mucus in the stools, that's also bacterial. But that particular blood and mucus means bacillary dysentery. At that time, this child will not have the follicular tonsillitis or the cervical nodes. So, bacterial infections are localized. Another important point is that within a family, more than one member of the family is involved, because most of these viral infections are rapidly spreading and their transmissibility is very high. Measles, for example, is an important respiratory virus, and the infectivity, transmissibility of measles is very high. So within the family, immediately the other child or the other person will be infected. Influenza, COVID, these are all the viruses which have high transmissibility, and that's very important to note. So within the family, more than one member will be involved, and within the community there will be more than one family involved. So my family will be unwell, some XYZ doctor who is staying nearby, his family will be unwell, any other family in the same locality will be unwell. So more than one system in a child, more than one member in the family, and more than one family in the community, that is viral. While in case of bacterial infections, it is only one single system involved at a given particular time. Another important difference between viral and bacterial infections is that when the fever comes down, say you give paracetamol for a child with fever, with cold and cough, and fever comes down, then the child will remain absolutely normal for the next 6 hours. Okay, he will be as normal as ever. And mother will say, "Oh, Dr. Jog, very good. You have given very nice treatment. Now the child has come back to almost normal." While bacterial infections, the mother will say, "Sir, it's okay. The fever has come down, but the child doesn't appear to be the usual self." Okay. Usually, my son will hit his brother. He will throw the objects from one place to other. He will, create a lot of, chaos in the house and so on and so forth. But today something is different. Even though the fever has come down, so in the interfebrile period, that means when the fever is on the lower side or almost normal, the child doesn't appear normal. He is not playful. He doesn't eat well. He doesn't smile. And that is bacterial infection. So, our colleagues, if they are aware as to what is viral and what is bacterial, it will be very, very easy for them to decide whether this child requires treatment. So, in general, viral infections, they are self-limiting, and by the end of 3, 4, 5, 6 days, usually they become normal. But over last few years, particularly over last 15 years, after this pandemic of influenza in 2009 and the pandemic of COVID in 2020, 21, 22, we have learned that the viral infections could be biphasic. The second phase begins after 5, 6 days. There is a cytokine storm, and the same viral infection which appeared to be simple in the beginning is not that simple. So, whenever a child is brought to me today, and when parents they say, "Sir, is it viral?" I say, "Yes, it's viral." But I make it a point to call them again and see that they come to me after 5 days, because I want to examine whether this child is absolutely normal. Because if I do not call them, and if the child worsens, and if they are under the impression that, "Oh, Dr. Jog has said that it's viral, nothing to worry," then it's possible that the child may worsen without our knowledge. And that's why I appeal to all my colleagues and all the listeners of this meeting to call every child for follow up after 5 days, particularly those with viral respiratory infections, because we want to rule out that there is nothing serious which is developing after 4 or 5 days. In my practice, I do not charge my consultation charges for the follow up, because on day 5 or 6 I am learning, and I am giving my fees to the patient as if I am learning. So that's the Guru Dakshina, because here Guru is the patient. And remember, in our practice, who teaches us? The patients are the ones who teach us. So you have to keep learning from them. And that's why, as a part of Guru Dakshina, I do not charge them for the first follow-up visit. Of course, that's a part. But what you should remember is that one must be clear. So if you want to avoid antibiotics in the first few days of fever, cold, and cough, and behave rationally, then you must remember that viral and bacterial infections are different, and you should be able to differentiate the two. And of course, these viral infections, as I said, can vary from very mild to very severe infections. And after the COVID era, the pediatric viral respiratory infections have changed. During COVID, children were indoor. They did not go outside. So they did not develop immunity against some viruses. For example, respiratory syncytial virus, hand, foot, mouth disease, adenovirus. All these, they came back as if in vengeance after the COVID pandemic was on decline. And that's why it is very important to know that, when you speak to the parents, tell them that, see, children have not developed immunity during the times of COVID, and that's why now that the child is getting these infections is partly because this child is not having any immunity against certain viruses. We have seen that after COVID, in some areas where measles vaccination was not up to the mark, there were, epidemics of measles also. Okay, we saw hand, foot, mouth disease, immediately following this COVID, and so on and so forth. So let us see one case where there is a 6-year-old girl who attends the daycare and presented with rhinorrhea and a daytime cough for 8 days. Okay. And this particular girl had fever for 2 days, and the appetite is poor. And we can say that this child only has rhinorrhea with a daytime cough, and there is nothing except that clear rhinorrhea. So, obviously, when the remaining examination is unremarkable, it appears to be viral. And one should know the viruses which most commonly cause the respiratory infections in children. So when we discuss about common cold, there are viruses which start their journey with common cold. For example, human rhinovirus, coronavirus, okay? But some of them are having other associated signs and symptoms. For example, respiratory syncytial virus starts with cold, but then progresses to bronchiolitis, that is tachypnea, increase in the respiratory rate, particularly in children under the age of 2, particularly under the age of 1 year. Okay. Then influenza. I say that, influenza is the father of all the influenza like illnesses. What do you mean by influenza like illness? That's nothing but a child coming with fever, cold, and cough. But influenza has severe headache, onset of fever with chills, pain in the muscles, and weakness. Okay, so you can always differentiate influenza from others. Parainfluenza, for example, comes with croup, that is stridor, inspiratory stridor, and the child will have barking cough, and the child will have hoarseness of voice. Adenovirus will produce pharyngitis along with involvement of conjunctiva, along with mesenteric adenitis, and so on and so forth. Enteroviruses like Coxsackie A will produce ulcers on the back of the oral cavity on the palate, which is called as herpangina. So they may start with cold, but the further signs and symptoms will help you differentiate between different viruses so that you can tell the prognosis to the parents. Suppose a child comes with herpangina, that is, ulcers at the backside in the oral cavity on the palate. Then the parents say, sir, he's so terribly, crying because of pain and not eating and having drooling. What is going to happen? What do we do? So you have to tell them that, see, this is a self-limiting condition and it will be all right within 7 days. So the parents are, alleviated. Their anxiety is alleviated. This is very important. So knowledge of the virus will, help you to tell them the prognosis as to what is going to happen to this child over the next 5, 6, 7, 8, 10 days. Okay, so in general, this common cold is one which occurs about 6 to 8 times in a year, and 10 to 15% of children, you can have even 12 infections per year, and the incidence of illness decreases with increasing age, and by adulthood it's hardly 2 to 3 illnesses per year. And children who are in the daycare during the first year of life, they get 50% more colds than children who are cared at home. And what happens is that the child has a scratchy, sore throat, nasal obstruction, rhinorrhea, and two-thirds of the children have associated cough, and the cold may last for 1 to 2 weeks. And along with that, there could be fever and constitutional symptoms, but not that bad as influenza. There could be change in the color or the consistency of the secretions. That means the watery rhinorrhea can change into yellow purulent like secretions, but this does not indicate that the child has sinusitis. Okay, so if there are swollen and erythematous nasal turbinates, okay, that means you just elevate the front of the nose and look inside the nasal cavity, you will find that the nasal turbinates are swollen and erythematous. Okay, so these children probably require only supportive care, some uh, degree of good hydration, and warm fluids, and saline installation. And sometimes the cough and the cold remedies are also not required under the age of 6 years if the children are otherwise symptomatically comfortable. Okay. Sometimes we might have to use first generation antihistaminics to reduce the rhinorrhea, and some products like vitamin C or guaifenesin, they're effective as placebo for the treatment of cold symptoms. This graph is very important, and it will help our colleagues to explain to the parents that in uncomplicated viral upper respiratory infections, usually the fever is the one which is on the higher side in the first 1 or 2 or 3 days, and then the fever comes down. But as the fever comes down, the respiratory symptoms begin. So the child will start coughing after 4 or 5 days, and slowly over 10 to 12 days, the respiratory symptoms will go down. So, appearance of cough in a child with uncomplicated viral upper respiratory infection does not mean that you have to act again vigorously and give antibiotics. Okay, again, second important thing, this is rational. Okay, so first is to differentiate viral from bacterial, that is rationality. Second is to remember that the natural course involves that the fever comes down and then the respiratory symptoms begin, and you need not give any antibiotics for those respiratory symptoms which come up after the fever starts subsiding. Okay, so in case if the child has some red flags which suggest severe disease or complications, then one should be aware. And of course, all the audience is well versed with these clinical red flags, which include flaring of the alveoli, movement of the neck muscles, rapid respiration, a child who is breathing very fast, has altered sensorium, either drowsy or irritable. All these symptoms are related to the hypoxia. Hmm. Along with this, many times parents these days they do have pulse oximeter in the house. After COVID, people have started measuring even the oxygen saturation, and many times it is possible for us, in case if parents call us on telephone and ask us to what should be done, then in case if you speak to them and if the parents are very educated, you can ask them to put this pulse oximeter on the first finger, that is the toe, or in case of adults you can put it on the thumb and check the oxygen saturation. If it is above 92, one need not be worried. Many times in children with bronchiolitis, it so happens that outside the the child appears more or less normal, but then the oxygen saturation is not normal. And it's very important that in case if if parents speak to you and if you have even slightest doubt that the child is irritable and crying, then it's better that you call the parents to the hospital. My teacher always used to tell me that whenever a child has gastroenteritis and the child is continuously crying, remember, Pramod, it's dehydration. And when a child with respiratory infection, bronchiolitis, tachypnic child, he is excessively crying, it is hypoxia. Okay, so the medication is not a sedative. So don't give any sedative medication on telephone. Don't tell them, okay, give this like diphenhydramine or give this trichlorophos or something. Please don't do that, because the child either has dehydration in gastroenteritis, or hypoxia in respiratory infections. This is very important. And that's why please see that the dehydration is corrected, hypoxia is corrected, and then only that irritability will go down. So red flags are very important. And tell the parents that, these are the red flags, because any child with influenza can, complicate into pneumonia. Any child with upper respiratory infection like even measles can complicate into pneumonia, and that is why you have to remember that there are some important red flags. One more important thing is that whenever a child has such red flags and respiratory symptoms, it is the most important indication for giving oseltamivir, which is the antiviral agent, because children with influenza are classified into three groups: A, B, and C. A are the ones, where have mild fever, cold, and cough. Otherwise, the child is playful. B category is where the respiratory starts increasing and the child is also in the high risk category. For example, the child has asthma, or child has congenital heart disease, or people who are having diabetes, or a pregnant mother, or a person who is on steroids for nephrotic syndrome. So many conditions. So if a child has some high risk condition in addition to respiratory infection, then it's again an important indication for giving oseltamivir. And the red flags, like the ones that I told you, are a definite indication. So a child who is hospitalized for pneumonia, you have to consider giving oseltamivir. And these are also the children who need to be investigated by doing a throat swab, because it's very important that whenever a child is sick and admitted to the hospital, you know what is the organism, whether it is influenza, whether it is some other virus, whether it is a bacterium which is creating a problem. So it's important that at least in the hospitalized patients, you do the nasopharyngeal swab. Okay. So we saw that this particular child had common cold, but the case has progressed. And for a week, it appears that the child has improved, but again, the child develops high grade fever. Till now, there was not much of fever. And now the secretions have become mucopurulent, very thick. And this child also, when lies down on the bed, starts coughing more. This is called as a post-nasal drip. And this is very classical of acute bacterial rhinosinusitis. Now, here you will notice one point that I have written, it's bacterial rhinosinusitis. Okay. First one was only rhinitis or rhinosinusitis. Okay. But rhinitis is viral, but bacterial rhinosinusitis is bacterial. And remember, it can present in different ways. Initially, the child will have cold and cough for 10 days. The child won't improve and come to you after 10 days. Or right since the beginning, the child will have fever going on for 3 days, followed by purulent discharge from the nose, or there could be return of symptoms. That means initially the child, as we saw in the earlier case, the child was appearing better. There was a resolution of symptoms, but again the fever has appeared and the rhinorrhea is increased and the cough has increased. So bacterial sinusitis can present in different ways, and there are some organisms, particularly Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis. These are the organisms which are responsible for the bacterial sinusitis part of it. Okay. So sinusitis in 70% of cases is bacterial, and only in 30% cases it's viral. And the drug of choice for the treatment of sinusitis, acute bacterial rhinosinusitis, is either amoxicillin or amoxiclav, depending on the organism which is suspected. Okay, let us see another case where there is a 6-year-old boy with fever, throat pain, and vomiting. And on examination, the child has swollen the red tonsils and tender cervical nodes. Note down these important features: red tonsils and tender nodes. Whenever you come across a child with fever, throat pain, vomiting, along with these, then you must think of acute tonsillopharyngitis. Okay, now remember that tonsillopharyngitis in 70% cases is viral. Okay, that's why do not jump to give antibiotics. But in case if a child has follicles on the tonsils, those yellow spots on the tonsil, along with tender cervical nodes, then you are fully justified in giving antibiotics. Okay, that is the only one condition in the upper respiratory tract where you probably are justified in giving, antibiotics empirically on an educated guess. Okay, this is rationality. Okay, here, if you give antibiotics, nobody will say anything. But in general, you should know that tonsillopharyngitis in 70% cases again is viral. And you can see that on the back side, you can see that there are exudates on the tonsil. And it's many times important that you differentiate the viral tonsillopharyngitis from streptococcal pharyngotonsillitis. So, as I told you in the beginning, viral tonsillopharyngitis means the child will have other parts also involved. So, the child will have conjunctivitis, coryza, cough, might have diarrhea. As I told you, it could be associated with hoarseness of voice, and then you could have rash on the body. And if it is bacterial, the bacterium which produces tonsillopharyngitis is Streptococcus pyogenes. This is known as group A beta hemolytic streptococcus, nicknamed as GABHS. And remember, this bacterial infection of the throat is common above the age of 3, 4, 5 years. In younger age, less than 3 years, it doesn't happen. Okay. In fact, if tonsillopharyngitis is seen under the age of 3, you have to think in some different manner. So it is not bacterial. So if a child comes with fever, headache, and nausea, and tonsillopharyngeal inflammation, and tonsillopharyngeal exudates, and sometimes some petechial spots on the palate, and tender anterior cervical nodes, then you have to think of bacterial. And on day 2 of infection, usually these children, they develop scarletiniform rash, red rash. This is typically known in case of scarlet fever. And right now, in the city of Pune, a lot many cases of scarlet fever are going on, and some of the schools have sent emails to the families. Of course, these are the schools from the higher strata of the society, where they have appealed to the parents that it's better that the children are kept at home, because it's a highly contagious disease. This streptococcal scarlet fever is highly contagious and immediately spreads to other children. This is rationality. So you should know that this child has high fever, has very bad throat, he has a tender node and rash on day 2, and the child is looking really unwell. This is bacterial. Okay, here you are fully justified in giving amoxicillin. Why I'm trying to tell you all this is because this is rational approach. And uh, usually we continue to practice all throughout the lifetime without thinking of many of these things. Just as the child comes with fever, give paracetamol. He comes with red throat, give amoxicillin. But we never think that 90% cases of fever, cold, and cough are viral. And one of the treatable viruses affecting upper respiratory tract is influenza. So we should think that oseltamivir can be the choice in a particular child where we suspect influenza. So that should come to the mind first before amoxicillin or amoxiclav. Okay. And there are some scoring systems where if you find that the temperature and tender anterior cervical nodes and tonsillar exudates are present, then they are given 1 mark. In fact, absence of cough goes more in favor of bacterial infections. Okay, and that's why you can give 1 mark to that. And as I told you, if the age is between 3 and 14 years, then these children, they get additional 1 mark. Okay, but an old child above 15, they don't get all these streptococcal infections to that extent. And that's why this scoring system many times is used for finding out whether it is viral or bacterial, though an experienced pediatrician or a physician need not use these scoring systems. We can always make it out from all that I have told you till now. And as I told you, if the tonsillopharyngitis is bacterial, then the drug of choice is again amoxicillin, but the treatment has to be given for 10 days. Okay, it's not for 3 or 4 days. And remember, there are some situations which may baffle you. So just have a look at this and tell me as to what you think in this particular situation. Can anyone guess what this is? I will also show you another picture so that you can understand as to what is the difference in the two. In the first picture, you can see that there are ulcers on the anterior part, on the tongue, on the lips. Okay, this is herpetic gingiostomatitis. And In the second picture, you can find, as I told you in the beginning, enteroviruses like Coxsackie A producing ulcers on the back of the palate, posterior side of the palate. This is herpangina. So remember that herpetic gingivostomatitis is a highly contagious, painful oral infection caused by the herpes simplex virus, that is HSV1, and it frequently occurs in children between 6 months and 5 years. Okay, it also affects the adults, no doubt about it, and the child has high fever with swollen bleeding gums and rapidly spreading painful and shallow yellow ulcers, okay, on the mouth, lips, and also on the throat. And of course the treatment is with hydration and managing pain with analgesics. And of course certain times we have to use antiviral medications like acyclovir to shorten the duration of illness, but it all depends on the individual judgment. And in the second case, as I told you, this child who has herpangina, usually it's a self-limiting condition, and by the end of 7 or 8 days, usually the child will recover. But during the course of the illness, on day 3, 4, and 5, the child is, terribly under pain, and there is excessive drooling. There could be fever, and that is the time when one has to be rational. Here, the temptation to give antibiotics has to be avoided. Out of ignorance, many of our colleagues, they will put the child on amoxicillin or amoxiclav, which is not justified. Okay. Now, in routine pediatric practice, we need not test the throat swab for viral etiology. Routine pediatric practice. Okay. That is because, as I told you, majority of them are self-limiting and children are usually not serious. But if a child who has suspected influenza, the child is from the high risk category, or if the respiratory rate is increasing, okay, or if there is someone in the family who needs to be protected from the child, because the child is the one who is going to transmit infection to adults. Influenza is primarily an infection of children, and it transmits from a child to the adult. Okay, so we must know what is the problem. So in case if a pregnant mother, gets infected, or a diabetic father gets infected, or an asthmatic grandfather gets infected from this child, then it's always better to test so that we know that this is not influenza or this is influenza. If it is influenza in that child, as I told you, influenza spreads from child to adults, and that's why we can immediately treat the child and give prophylaxis to the contacts. This is important. So if you want to really be sure as to what it is, you can test for viral etiology. Sometimes you may get, in addition to influenza, you may get other viruses like rhinovirus, which are sometimes, like innocent bystanders. And sometimes it's possible, in case if the throat swab has not been collected with a proper skill, the test may be negative in spite of the child having influenza. Okay, so this is called as a false negative test. Okay, this rarely happens, but in case if you find that the child has positive test for influenza like H1N1 positive or H3N2 positive, usually it is influenza, because this false positivity is not something very common in influenza. Almost in 90-95% patients who show you the throat swab positive will have influenza. Okay, and then you should interpret this positive viral PCR result in the light of the clinical presentation. But as I told you, there are some commensals in the throat, and many times they are also detected. But in case if you speak to the pathologist or the microbiologist, then they will be able to guide you as to whether that particular result of the throat swab is to be taken seriously or it need not be. However, please remember, go by your clinical judgment. Okay, whatever is the result, if you get influenza positive, well and good, then you can very well go ahead and treat with oseltamivir. But in case if the features are suggestive of influenza and the test is not positive for influenza, even then use your conscious, use your intelligence. If the child is terribly pathetic with headache, fever, chills, pain in the muscles, weakness, then please continue with oseltamivir, because even WHO has said that if you find the symptoms and signs suggestive of influenza in the face of epidemic of influenza going on, of your colleagues, getting so many cases of influenza, you are fully justified in giving oseltamivir early in the course of illness. Before 48 hours, it works best. Okay, it's very important. Let us see another child who is a 3-year-old child with, you know, some problem comes to your emergency room at 2 o'clock. The problem is that he has sudden onset of breathing difficulty, and this particular problem all is preceded by cold and fever. I already told you that sometimes there are viruses like Respiratory syncytial virus where the onset is with cold and fever, but later on they develop the infection of the lower respiratory tract, and that is the involvement of the small parts, bronchioles of the respiratory system. Okay, and these children, they develop hypoxia, and they also get many problems because of respiratory syncytial virus. For this child, what happened was the child was restless, but he was comforted by the parents, and there was audible stridor at rest, worsening while crying. Stridor is an inspiratory sound. So the child will have this particular type of inspiratory sound, and there will be some intercostal retraction. That is because the child needs more and more oxygen, and the saturation is 92%. So this is a condition which is known as croup, and depending on the various criteria, it is classified into mild, moderate, or severe. Of course, if there is hypoxia and lot of distress, then we call it as a serious child. But as I told you, as the larynx is involved, the condition is known as laryngotracheobronchitis. As the larynx is involved, there is, narrowing of the part where air goes inside. And because of the narrowing, there is stridor. Okay. As larynx, which is the voice box, which is involved, there is hoarseness of voice. Okay. And as trachea and bronchi are also involved, which are relatively larger, pipes, this particular child will have barking cough. Okay, so all these three are very important. In fact, it's the triad of this laryngotracheobronchitis. It's almost always viral, but there are some conditions like diphtheria and epiglottitis where you have to be very careful. Okay, where the child will have stridor, but then you have to be careful in examining the throat. If you find a grayish patch of diphtheria, now diphtheria fortunately has gone because of the immunization in the entire world. However, diphtheria keeps occurring at some places where the booster doses are usually not given. And there have been reports, particularly from the state of Karnataka in our country, where the booster doses were not given, and that's why children they came to the OPD with diphtheria. But remember that if a child has very high fever, has stridor, it's mandatory that you examine the throat carefully and look at the tonsils and the pharynx and look out for a grayish white membrane, which is suggestive of diphtheria. Okay, that's something which is bacterial. But in general, this group is something which is viral and caused by parainfluenza viruses. And as I told you, based on the stridor and chest retractions and cyanosis, heart rate and respiratory rate, mental status, we can always classify into mild, moderate, and severe categories. And the treatment for croup is basically to give a position of comfort and observe in the emergency room for almost 4 hours. And you can use, oral or nebulized or intramuscular steroids. And you can also use nebulized adrenaline if symptoms worsen. And after 4 hours, if the child is asymptomatic, then you can discharge the child and give them parental advice to observe the child. And that's very important. Remember that viral respiratory infections, they present so differently. We never discuss, stridor and laryngotracheobronchitis and diphtheria and whooping cough and bronchiolitis in adults, isn't it? So this is because the respiratory airway is narrow, and that is why these children are the ones who have so many problems. It is said that the resistance of the respiratory system is inversely proportional to the fourth power of the radius. That means narrower the smaller or the airway, the resistance is more, and that's why children they worsen and become hypoxic. Let us see another case where there is a 7-month boy brought with complaints of increased respiratory movements and difficulty feeding since one day. This is the case that I was trying to tell you, where again there was history of runny nose and fever for a day or two, but here the child has tachypnea, retractions, and wheezing. The earlier child I told you had similar presentation with runny nose and fever, but this chap has, landed into tachypnea, while the earlier one landed up with stridor. Okay. And here, remember, the child has bronchiolitis, which is nothing but the pulmonary infection of young children, particularly under the age of 1 year, where there is wheezing. It starts as cough and coryza, which leads to respiratory distress in 2 to 5 days with fever and tachypnea, wheezing, prolonged expiration. And these are the children, younger the age, they may have apnea, okay, sudden cessation of breath, dehydration, and respiratory failure. And this is commonly because of the respiratory syncytial virus in almost 80% of the cases. And they are to be managed by, observing them. Basically, in case if the child has hypoxia, if the oxygen saturation is less than 90 degrees, 90%, or particularly children with underlying cardiac or pulmonary disease, or a child who is a preterm baby with all these problems, then they are to be admitted. And the treatment involves oxygen and nebulized bronchodilators and supportive therapy. And there are some experts who use hypertonic saline or nebulized adrenaline. Remember that the basic principles while managing viral respiratory infections are very simple. One, you maintain the hydration. Number two, you maintain the oxygenation. Okay. Unfortunately, our colleagues in some places, if they are not really updated, as soon as a child comes to the OPD, the standing instruction is that give ABC. That is, antibiotics, bronchodilators, and corticosteroids. This is absolutely irrational. Okay. That's why what we discussed today was rational approach. When you know that this is viral, number one, you need not give antibiotics. Number two, once you know that this is likely to be influenza, you are justified in giving oseltamivir. Number three, if you feel that this is bacterial, you are justified in giving amoxicillin. If you find that the child is getting hypoxic, you are justified in giving oxygen. Okay. So these are some of the important principles, and hydration is extremely important. Examination of the child in the mother's lap is very important, because if a child is restless and he is not happy when you examine on the bed, then the hypoxia may worsen. He will not allow you to examine. So comfort the child. Okay. Your examination should not create further problems. For example, epiglottitis. You have to be extremely careful when you examine the epiglottis, because simply touching the tongue depressor, if it touches the epiglottis, the child can go in sudden spasm and there could be problems. So there are different clinically important points which you must remember when you are treating a child with viral respiratory infections. And one should also remember that in case if you are tempted to use antibiotics, you have to be very, very, very careful. You have to control your mind. Okay. Just as in life, as we grow older, we have to control many things. Like we have to control our tongue as far as eating and speaking is concerned. As you become older, you have to be more responsible for your health, for your image, and so many other things. Similarly, you have to be careful, because what you write in the prescription is followed by others in the medical community. So if one feels, oh, for any child coming with cough, cold, and fever, Dr. Jog is prescribing antibiotics. So is it right? Is it rational? And then, they will also try to imitate the same practice. If at all you do all this, nobody is there to stop you. But then the antibiotic resistance in the world will continue to increase. Okay. We are all responsible pediatricians and physicians. And that's why it is important that we put a control. And, I always say that the pen, the decision to prescribe any medicine, it goes through the hand. But then there is a head at the top. And this head is the one which is directing the hand. Okay. And that is why, remember that your pen is controlled by the orders given by the head, that is the brain. And that's why the brain has to be updated. That is exactly the reason why we are having such webinars. Okay. And remember, already I told you that influenza clinically differs from other viral respiratory infections. I already told you that the medication oseltamivir is an important antiviral agent. Let me tell you a bit about influenza and oseltamivir. Now, remember, influenza, it has a typical nomenclature where individual virus, Basically, it's of three types, either influenza A, B, or C. And type A virus has, two antigens, which are glycoproteins, which are situated on the outer side of the influenza virus. Okay. So this H and N, these two antigens are glycoproteins, and they are made up of different amino acids. And H has a particular amino acid sequence, and N has particular amino acid sequence. And there are 16 H antigens and 9 N antigens. And combination of one H antigen along with one N antigen together, will produce one particular type of influenza virus. For example, if it is H1N1, it becomes H1N1. If it is H3N2, it becomes H3N2. By far, these are the two important, strains which are circulating in the atmosphere. Okay. And after 2009, that is our pandemic year, swine flu, so called, now that particular strain is still there in the atmosphere. But now different other strains have also come in the atmosphere. Okay. Now, most important thing is that the amino acid sequence of these viruses changes every year. It changes. Why? Because this is an RNA virus, and RNA viruses are notorious to change their structure very rapidly. COVID virus, you know that by the time the first vaccine was being given, the new strain came, because it's a virus, RNA virus, which changes very rapidly. Influenza, RNA virus. Okay. So RNA viruses are very notorious, and that's why every year even WHO has to collect the data from all over the world and decide as to what is the strain circulating. And just as we know that the kundali of the boy and the girl should match before marriage, as per some people who are very, very religious, the vaccine, if it has H1N1, H3N2 circulating in the atmosphere, and the same strains are in the vaccine, then well and good, there is a lot of protection against influenza for that particular year, for that particular child. But the next year, the same influenza vaccine will not work, because the virus has changed. Though to slightest extent, there is a change. So a different vaccine will be required. And this particular annual change is known as antigenic drift. Okay. But what happens is, periodically, like say in 1919, 1957, 1968, 2009, a major change occurred in the virus. Okay, so the virus from the bird and the virus from the human beings got mixed up in the third party like a pig, and a new novel influenza virus came up. That was the one responsible for the pandemic. So there have been four pandemics till now, as I told you, and these four pandemics had different viruses, but this was a major change, a major shift. That means it was not a minor change in the amino acid sequence, but it was a major change. So what I'm trying to tell you is that the influenza as a virus differs clinically also from other viral respiratory infections. Others are relatively mild. Okay, but influenza will have high fever, fever with chills, headache, and muscle pain and weakness. In fact, many times, children, even 9 or 10 or 11-year-old children, are to be lifted by the parents when they are brought to the clinic. Okay. And as I told you, there are some children who are at a higher risk of severe influenza, and they are the ones who definitely need to be given oseltamivir, even empirically, whenever they come to you with fever, cold, and cough. Okay. Of course, the antiviral treatment for influenza should be initiated before 48 hours, as fast as possible, because the molecule oseltamivir, the drug, is a neuraminidase inhibitor. I told you about H and N antigens. H is the antigen which is responsible for attachment to the respiratory epithelium. So the viral RNA particles, they enter into the respiratory epithelial cell, they replicate themselves, and neuraminidase is the enzyme of the virus which allows these viral particles to get out of the respiratory epithelial cell and attack other normal respiratory epithelial cells. But oseltamivir blocks the neuraminidase enzyme, and that's why it's a neuraminidase inhibitor. So earlier you give in the course of illness, this release of the virions will be blocked. So the virus will enter, it will get attached, it will replicate, but cannot get out. It will get blocked inside the respiratory epithelial cells. That is the beauty of this molecule. So give it early. So when you give oseltamivir early, the spread of infection in that particular child will be halted. In 2009, I remember, even when children used to come after 4 or 5 or 6 days, when we started oseltamivir, the severity of influenza infection got reduced, hospitalization rate reduced, mortality reduced. So even if children come late, you can use oseltamivir. Okay, and of course, one should know that influenza virus is a virus which spreads through secretions, droplets, cough, sneezing, cold, and that is why you have to be extremely careful when you cough or sneeze. Use handkerchief. Use different strategies for coughing. For example, usually we cough in the palms, but it is better that you cough in the elbow, so that when you cough in the palms, you unknowingly touch your hands to the tabletops, the staircases, the laptops, and viral transmission is more. So you have to wash your hands after you examine each and every child. You have to avoid shake hands. You have to keep at a distance of a hand's distance from the other person. So all these precautions are related to the hands, okay? Because particular transmission, as I told you, influenza is a highly transmissible virus, okay? So you have to take all those important precautions, and that is why always remember that influenza is a preventable disease. You have to take influenza vaccine every year. If you suspect influenza, you have to be very, very careful and put the child on oseltamivir as fast as possible. Be rational. If you feel that the child is having simple viral infection, then you need not give antibiotics and give only symptomatic therapy. But in any case, see that the parents are advised about the danger signs, the red flags when they come to you for features suggestive of viral respiratory infections. And above all, to conclude, I must say that try to be as rational as possible, because the days are changing. We have very, very few antibiotics in the pipeline, and unless we take care of those antibiotics, there is no one else who is going to care. A layperson doesn't know what is antibiotic resistance, and he simply will do whatever you tell him. Okay, so again, to conclude, with folded hands, because we are not going to shake hands from today onwards, because influenza virus and so many other viruses will spread by shaking hands. So in front of you, even though it's a webinar, I will just say namaste, and I hand over the proceedings to Dr. Prashant and stop sharing my screen. Thank you.
Thank you, sir. Thank you very much. Namaste again to everyone. Thank you. Thanks for this wonderful presentation on influenza changing role of infectious disease in our country and the need for taking care of antibiotic resistance, prevention of antibiotic resistance. Thank you so much. I'm sure the audience has benefited out of this discussion. And thanks once again the marketing team, Payal, Akshata, for this support, and sales team of Wipro and IT team Sanjana. Thank you very much. Sir, you can log off, sir. I wish you a very pleasant afternoon. See you soon.
Thank you.
Thank you.
Thank you,
Thank you
doctor.
so much. Thank you,
Thank you.
doctor. Have a great day.
Thank you.
Thank
Thank you very much. Yeah.